cortisol gets a bad rap unfairly, right? Everybody looks at, well, cortisol is what's going to put fat around my middle, and sometimes I'll talk to patients. I actually just saw a new patient yesterday, and she said, I just briefly mentioned something to her about having low cortisol, and she said, well, I got all this fat around the middle right here that I've been putting on, and I thought that was associated with high cortisol. Well, there's some commonalities between the highs and the lows, so it's not just high or just low on this, okay? The truth is that by the time most patients ultimately get to us, they're in a more of a chronic scenario. They're not in that acute scenario. Elevations in cortisol, when we do see those do pop up from time to time, but that's more of an acute presentation. That's not your chronic patient or your chronic hormonal deficiency there. They're producing the adrenal gland. That's one thing that most people know about cortisol with this, especially in the functional medicine world. But I think the part that really is not emphasized enough with cortisol is the fact that it's a glucocorticoid. And that is, if there's anything on this slide that you want to hone in on, it's the fact that it's a glucocorticoid. And really, when you're thinking about this, it's the fact that as that glucose starts to drop, your cortisol has to kick in to bring that back up. So, and I'll talk more about this in some of the symptomology stuff, but if patients are complaining about hypoglycemia, or if they give you that immediate, hey, I get tired 2, 3 o'clock in the afternoon, first thing you should be going for is what's causing the hypoglycemia. Is it just lack of eating, or is it that they don't have enough cortisol available to bring that back up? And it's, even if they're not eating frequently, the cortisol, even if they miss a meal, should be able to kick in enough to keep that glucose level up. Right? The next one here, the anti-inflammatory effects of cortisol, most of us all know that. That's the whole, it really doesn't matter what specialty of medicine you're in, whether you're thinking along the lines of something like prednisone or even the corticosteroid injections, those types of things. I mean, we kind of all know the anti-inflammatory effects here. And then the immune suppression. So again, let's go back to what cortisol is actually doing is it acts as an anti-inflammatory. So these cytokines that actually stimulate the increase in the B cells that are going to drive these immune responses, cortisol actually down-regulates the production of those, or it shifts the production in those. So think about this in terms of what we do in day-to-day clinical practice. In clinical practice, we're telling someone, hey, you have a food allergy, right? And that food allergy is manifesting itself because you're also, or your symptoms are manifesting because you're also, your immune system is reacting against a tissue in the body. So the way we go and check that is we look for antibody production. Well, essentially, and those are going to be derived from your B cells. Essentially, what's happening here is that prednisone or any of these other anti-inflammatories are suppressing that production of those antibodies or those other B cells. So think about that when you're doing the different tests, when you're ordering food allergy panels or antibody profiles, that type of thing, that if the patient's on any type of immunosuppressive drug, any type of cortisol mimicking type drug, that could be an influencer on the results that you're getting back there. So you don't want to give the patient a false positive on that. Or I guess that'd be a false negative, not a false positive.